This lecture will be about adenocarcinoma of colon. This is actually the most important area from the gastrointestinal tract in pathology for second MBBS. The reason is that adenocarcinoma is the most common malignancy of GI tract. Now, when it comes to the colon, we have that colon is a really large structure. There is this part of ascending colon, transverse colon, descending colon, and the sigmoid. So the thing about adenocarcinoma is that it can equally affect any part of the colon. So the distribution is equal over the entire length of the colon, and we roughly divide the colon into two parts. That is the area on the right side of the colon, and here we have the left side of the colon. Now we initially begin this session with the discussion of the clinical features. When the cancer affects the right side, usually the presentation is an iron deficiency anemia. So the patient is an elderly patient or a postmenopausal woman who presents as iron deficiency anemia. So the features of iron deficiency anemia, we know there is fatigue and there would be weakness predominantly, there would be pallor and so on. Whenever we see an older woman, a postmenopausal lady, or any older person, be it a man or a woman above the age of 50 who presents as iron deficiency anemia, we must compulsorily rule out adenocarcinoma of colon. So we consider it as a cancer of the GI tract until otherwise proven. So that's the dictum. So that's about the right-sided colon carcinoma. Now, when the carcinoma affects the left side, when the left side is affected, usually the patient presents with either there would be a pain over the left part, over the lower quadrant of the abdomen, or there may be alteration in bowel habits. So the bowel habits could get altered, or there might be occult bleeding, which could be tested. So any of these three features are usually seen. Along with that, there could be other features which are seen in any type of cancer, which could include weight loss and so on. So that's about the clinical presentation. Now we move into the etiopathogenesis of adenocarcinoma of colon. So what are the risk factors for? Most of the students would say that the most important risk factor is the diet, because that's how it is shown in the textbooks. But actually the most important risk factor is actually the age. Above the age of 50, the rate of CA colon increases twice by every decade. So that's the most important factor. And then we have the other factors, which include the dietary factor. And among the diet, there are two kinds of factors. That is, factors that increase the risk of CA colon and factors that decrease the risk. When it comes to increasing the risk, the most important factors are, first one, there is decreased dietary fibers, and second one is there could be increased refined animal fats. When it comes to decrease of risk, the factors which decrease the risk are the antioxidants, that is vitamin A, C, E, and the cruciferous vegetables such as the cauliflower, cabbage, and so on. Why do the fibers decrease the risk and animal fats increase the risk? So the mechanism is that the dietary fibers are responsible for the bulk of the stool. When the dietary fibers are reduced, what happens is that our stool goes really slowly through the colon. So it will take a lot of time for the stool to pass. When the stool is retained inside our colon, when the feces are retained, what happens is that there are colonic bacteria, right? These colonic bacteria will act on the stool and they will undergo oxidation, and they will produce toxic metabolites, and those toxic metabolites would induce changes in the mucosa of colon. So that's how the mechanism actually goes. So decreased fibers will increase the production of toxic metabolites by the gut bacteria, and that will lead to carcinoma. When it comes to animal fats, when the animal fats are increased, we know that to solubilize the fats, biles will be produced, right? So there will be increased bile production. So the bile contains cholesterol and bile acids, and these bile acids will be converted to carcinogens by the gut bacteria. So that's the mechanism. And both of these are actually kind of like an oxidation reaction, right? So the vitamins A, C, E, they are mainly antioxidants. So their antioxidant property will help us from carcinoma of colon. So that's about the age and that. Then we move on to the other factors. The other factors are the hereditary and the syndrome. So hereditary factors could be, first one is the familial adenomatous polyposis, so FAP. It's an autosomal dominant disorder. Anyone who has FAP, familial adenomatous polyposis, will 100% inevitably will develop colorectal adenocarcinoma before the age of 30. So therefore, such patients will undergo a prophylactic colectomy. The other syndrome is HNPCC. This is also another hereditary autosomal dominant condition, that is hereditary non-polyposis colorectal cancer. It is not just associated with colorectal cancer. It's also a complex of cancers will be produced in later life. It could increase other GI structures such as the intestine, small intestine, stomach, ovary. The genitourinary system may also get involved. So those are the two hereditary syndromes. In addition to that, we have our inflammatory bowel disorder, which is again a risk factor. Long-standing cases of inflammatory bowel disorder could progress to CA colon, and we know there are two IBDs. That is, one is ulcerative colitis and the other one is Crohn's disease. When it comes to the relative risk, the ulcerative colitis has a greater risk than Crohn's disease. The other risk factors are there, which are like previous history of colon cancer or long-standing tobacco use, family history of colon cancer. These are all other risk factors. Now we move on to the part of pathogenesis. So when it comes to pathogenesis, there are two mechanisms by how cancers are produced. The first one and the most important one is the adenocarcinoma sequence. That is, first from a normal mucosa, adenoma will be formed, which will then develop into or progress into carcinoma by a series of mutations. So that's our first pathway. And our second pathway is the microsatellite instability pathway, otherwise called as the MSI pathway. So these are our two main pathways. In addition to that, there are some other small minute pathways such as epigenetic alterations and all. We'll just speak about it later. We begin with our adenoma carcinoma pathway. This is the classic pathway, and it is responsible for more than 80% of the tumors. 80% of the tumors are produced or by this pathway or undergo this pathway. So here what happens is that here we initially have a normal colon. So this is our mucosa. Here we have our submucosa. In adenoma carcinoma sequences, what happens is that a series of mutations occur, and through the mutations, the normal colon first forms an adenoma, and later that adenoma develops into a carcinoma. So what are the mutations and the order in which they occur? So the first mutation which occur is the APC inactivation. That is, APC is actually a tumor suppressor gene. Now what do APC do? To know the function of APC, we need to know another molecule called as beta-catenin. So what is the role of beta-catenin? The role is simple. Beta-catenin forms a complex with other structures, and finally what happens is that beta-catenin will increase the cell proliferation. So this is the role of beta-catenin. We know that cancers develop, roughly we can say two important mechanisms can happen in cancers. That is, either the cell proliferation is really high and uncontrolled, or the cell death is absent. That is, the cell senescence or apoptosis are absent. So these two mechanisms are always found in cancers. So beta-catenin causes increased cell proliferation, right? Normally what happens is that our APC tumor suppressor gene, the product of APC tumor suppressor gene, will inhibit beta-catenin. And as a result, what happens? The cell proliferation is inhibited, right? But here the APC gene undergoes mutations and the APC is inhibited. As a result, what happens? As a result, the beta-catenin will have an uncontrolled activity. And because of the uncontrolled activity of beta-catenin, there will be increased cell proliferation. So that is the first mutation which occurs in the adenoma carcinoma sequence. And this we can call as the initiation step. Then the next mutation occurs, and the second mutation which occurs is the KRAS mutation in the KRAS or the BRAF genes. These two genes are proto-oncogenes. APC is a tumor suppressor gene, whereas KRAS or BRAF is a proto-oncogene. Now, what is their mechanism? They actually take up the second part. We said that cancers occur when either the cell proliferation is high or the cell death is very low. What happens is that because of this mutation, there will be decreased cell death. So apoptosis of the cells, which is a normal physiologic mechanism, that will be inhibited. So the cells do not die and they will predispose to the formation of cancers. So with these two mutations, what happens is that there is going to be an expansion, right? We have initiated with APC and now the tumor or the adenoma is expanding. That we call as the expansion. And then in addition to these two mutations, finally some other mutations add on to as well. So first one is the SMAD4 mutation, the SMAD4 or SMAD2. You need to remember the name of these genes. And there could be mutation of TP53, which is also seen in 70 to 80% of the cases. And as a result, again, further expansion to form an adenoma. So here what we see here is a polyp, right? And finally, one more mutation occurs, that is the telomerase mutation. We know that telomerase is responsible for cell senescence. Basically, after certain divisions, what happens is that cells will ultimately become old and they cannot divide further. When telomerase acts, what happens is that this mechanism is disrupted and cells can continuously divide forever without entering an old age or without stopping the reproduction or replication. And by the telomerase inactivation, we develop into a full-fledged carcinoma. So this is how an adenoma carcinoma sequence develops, and this is responsible for 80% of the tumors. Having said that, we now move on to the other pathways. So we have said that we have a second pathway, and that is the microsatellite instability pathway, which is our second pathway. The term has it. Here what happens is that microsatellites are unstable. What are microsatellites? Every chromosome we take, there will be repeated short repeats of sequences, which we called as microsatellites, macrosatellites, such depending upon their length. So normally these microsatellites are generally very unstable. When the DNA or when the chromosome replicates, a lot of times there will be changes in these sequences because of their instability, but it does not affect the performance because the DNA repair genes will act on these instability, and the DNA repair genes will correct the changes which has occurred. In colorectal carcinoma, this mechanism can get disrupted by either there could be a defect in the DNA repair genes, or even if the DNA repair genes are defective, but as long as these changes which have occurred due to instability, as long as they are not involved in the genetic part or the region of the chromosome where the genes are produced, it's not going to affect anyway, right? If the non-coding sequences are affected, it's not going to make a huge change in the function of a human body. But sometimes the microsatellites could be defective in the coding regions. So if the defect involves the gene, the area of the genes which are involved in coding of proteins, which will produce some function in our body, in such cases there is going to be alteration in the normal function of our cells, and that could lead to the development of carcinoma. There are two important coding regions. That is, if it involves the transforming growth factor beta receptor gene, or if it involves the BAX gene. BAX is a pro-apoptotic gene. So if the BAX gene, if these two genes have a microsatellite instability, then what happens is that their function is altered, and as a consequence of this, carcinoma can develop. And in addition to that, there are some other pathways which have really weird names which are difficult to understand. That is, one is the CpG island hypermethylation phenotype. So the term, I understand that you are not going to understand anything from this term, but the concept is really simple. We can remember this as CIMP, C-I-M-P. Now the concept here is really simple. For every gene, we know that this is our gene. It might be the gene in our chromosome. Along with the genes, there are a lot of other structures which alter the functionality of the gene. It's not just the gene itself. So there could be promoters, there could be inhibitors, there could be operators, and so on. Here what happens is that the genetic region is normal. The region of the coding sequences are really normal, but the defect could occur in the promoter region. Hypermethylation of promoter region occurs, which will inactivate the promoter, and as a result, the genes or the coding sequences are inactivated. Having said that, we now move into the part of morphology. So in morphology, we have the area of the gross and we have the area of microscope. We begin with the gross. One thing which we need to remember is that most cancers have similar gross presentations. That is, by similarity, what I mean is that the gross patterns are either it's going to be a mass, it will be seen as a projectile protruding exophytic mass will be seen, or it may present as a really opposite version of that there could be ulceration. So either there could be a mass formation or there could be an ulcer formation, where the cancer will erode the mucosa, submucosa, and go deep, or there might be a diffuse thickening. So they will not form a single polypoid mass, but instead they will involve the whole of the structure, and that will lead to a diffuse thickening. So these are the three types of presentation which are seen not just in carcinoma of colon, but it can be applied to a lot of cancers. It is seen in the gastric cancer, it could be seen in the cervical cancer, endometrial cancer, and so on. This is a common presentation of, or common gross finding of most cancers. When we come specifically to the carcinoma of colon, there are the 4 variants, just as what we have said now. The first one is this variant, that is the exophytic growth, which we can draw here as a protruding mass will be seen. Or then we'll have the opposite side, where there could be an ulcerative mass, or they may project as a diffuse mass, where we really will not see a single mass. Outwardly, we may not be able to see a single mass. And finally, when it comes to colon cancer, there could be another presentation. That is actually the annular, ring-like annular masses can develop, which has the potential, as we can see from the figure, to obstruct the bowel. So we'll speak a few words about each of these types. So this one, the first one here is the exophytic type, or the protruding outgrowth type. The second one here is the ulcerative type of growth. The third one here is the annular type, and we also have, in addition, there is a diffuse type. So we'll speak a few words or the important features of each of these. The first point about the exophytic type is that it mostly affects the right side of colon. It rarely causes intestinal obstruction. So that's about the exophytic type. When we move on to the ulcerative type can occur any area, and we always describe ulcers on the basis of their edges and the base, the margins, and so on. So how do we describe this ulcer? This ulcer will have irregular edges. The edges will be irregular, and there is going to be a kind of like an excavated area. That is, it's going to be a rough, patchy area. A rough ulcer will be seen. When we move on to the annular type, this is actually the most important among these types, because the reason is that the annular type will cause intestinal obstruction. And secondly, this is more seen on the left side. The exophytic type was seen on the right side of the colon, whereas the annular is seen on the left side of the colon. So that's about it. And finally, we move on to the diffuse type of colon. And in the diffuse type of colon, there is going to be diffuse thickening of the colon without formation of a mass. So that's about the 4 gross findings. So the important point to note is that when it comes to the annular type of cancer, when we look through the contrast enema, when we look radiologically after barium enema, what we'll find is that because of the constriction, there is going to be an apple core appearance will be seen. It also has another name, that is, it's also called as the napkin ring appearance. Now we move on to the part of microscopy. It's not morphology, it's actually microscopy. And for microscopy, adenocarcinomas could be either of the 3 types. They could be well differentiated, they could be moderately differentiated, or they could be poorly differentiated. If they are poorly differentiated, as the differentiation is reduced, what happens is that the number of glands will decrease as we go down. There are some variations as well, which will just mention the names. It's not that important. The first one is there could be a mucinous variant. Secondly, there could be a signet ring variant where there will be signet ring cells. Now moving on to the investigations. So it's a cancer and we need to take a biopsy, right? So we usually go for biopsy. Definitely we are going to go for an endoscopy for GI tract. So the endoscopy in the colon, that is known as the colonoscopy. Colonoscopy is the investigation of choice. Now to test, we have said that in left-sided colonic carcinoma may present as occult blood loss. So occult blood loss can be tested. Finally, we go for radiologic investigations using barium anemia. So barium anemia is where we find, if it's an annular lesion, we'll see the apple ring constriction or the apple core constrictions will be seen, appearance. We could also go for a USG to check for hepatic metastasis. So liver involvement can be tested by using a USG. And in addition to that, we also have to remember the tumor markers that are generally used. The 2 important markers are, one is the CEA, that is the carcinoembryogenic antigen, CEA, and the level of CA99. So the most important of these investigations is especially colonoscopy, which is endoscopy of the colon, and we can take the biopsy, or we can also look for the sigmoid if the sigmoid involvement is there. Now we move to the part of spread of tumors. So tumors can spread. This is common to all the invasive carcinomas. That is, there can be a direct spread that involves the tissue itself or the cells around the tumor cells. Then there could be the lymphatic involvement, there is a lymphatic spread, and there could be a hematogenous spread, that is through the veins and arteries, through the veins predominantly. There is, in cases of GI cancers, there is a possibility, GI or female reproductive cancers, there is always a possibility of transphelomic spread. That is where the cells can dislodge into the peritoneal cavity. So those are the 4 ways or pathways of spread. When it comes to hematogenous, obviously the portal vein is involved, and the portal vein drains to the liver. So the most commonly involved is liver. And before moving on to the lymphatics, we'll speak about the direct spread. So direct spread can occur by 3 pathways. If this is our colon, there are 3 possibilities. One is there could be a transverse spread, where the spread of tumor can occur transversely, and that could cause intestinal obstruction. So that is one possibility. The second possibility is a longitudinal spread. It could go distally or proximally and involve the other parts. And the third one is actually a radial spread. Radial spread means that from the mucosa the tumor spreads inwards into the submucosa, into the muscularis layer, and into the serosa layer. So that's an inward spread, is what we call as a radial spread of tumor. And when it comes to the lymphatic spread occurs actually by 3 levels. Those are the N1 lymph nodes, N2 lymph nodes, and N3 lymph nodes. This actually is a part of our anatomy. If we know the lymphatic drainage of colon, it really becomes easy. N1 actually means the lymph nodes which are present very close to the bowel wall. We can say that close lymph nodes that are close to the bowel wall. And second, these lymph nodes that are present or surrounding the entire colon, they will drain into the vessels supplying the colon, right? So colon is supplied by the ileocolic, right, left and middle colic arteries, or those vessels, right? So these are the lymph nodes. So N2 will be our lymph nodes which are present around the colonic arteries or colonic vessels, such as the right colic, mid colic, left colic arteries. And N3 is the further away. Where do these arteries arise from? These arteries arise from the superior and inferior mesenteric vessels. So the lymph nodes which are present further away, that is around the superior and inferior mesenteric arteries. So these are the N3 lymph nodes. So depending upon the lymph node involvement, we name them as N1, N2, and N3. Now the staging and prognosis. The staging is done by the TNM classification, and the prognosis is variable. The CA colon is responsible for 10% of the deaths in the population of United States. So I guess that's about the carcinoma of colon. An important essay, because this is, in fact, as I've said in the beginning, the most important carcinoma of the GI tract. So that's it for this video.